Welcome to Prepare Tennessee LTC, a podcast created to provide resources and information on the current topics experienced within Tennessee long-term care and skilled nursing communities. I'm your host, Rachel Turner, an Associate Program Manager here at Vanderbilt University Medical Center's Program in Disaster Research and Training. I'm here with Dr. Mohana Karlekar, a Section Chief of Palliative Care Medicine here at Vanderbilt University Medical Center. Please join me in listening to her presentation on palliative care.
I'm really excited to talk to you all about something I'm really passionate about that I think is incredibly helpful for all of us living in Tennessee, patients, families, as well as healthcare providers. And we're going to talk about palliative care as it relates to long-term care. In this first podcast, we're going to talk a little bit about palliative care, what it is, how it is different from hospice care. We'll talk about how to access palliative care and where people can get this in the community, whether it's outpatient or inpatient. We'll talk about a framework to think about prognosis and disease trajectory so people can get a better sense of how they're doing and what the road ahead looks like. We'll touch a little bit about palliative care in the COVID-19 pandemic and talk through some barriers that make it a little bit harder to get our best possible care in hopes that as we think through these barriers, we can actually put ourselves in the best foot forward to achieve our best care. So I want to start out with a story of a woman that I took care of who passed away in August. Let's call her Mrs. W. I met Mrs. W and her husband about 14 years ago when I came here. And at the time I met her, she had some minimal medical conditions, high blood pressure, and some underactive thyroid disease. And she lived with her husband in an area right outside of Nashville. And she, as her husband, was also very clear about what she wanted in terms of quality of life, what she wanted for her care. And over the next decade or so, what she wanted changed as things in her life changed. Her husband passed away at some point about 7-8 years ago, and her goals and wishes changed at that point. She unfortunately developed early dementia, and as she realized that was happening, she became even clearer about what was and what was not important. They didn't know when they began seeing me that I was a palliative care physician, but I think that connection worked really well because we were able to engage in conversations and empower her and her family to make sure the right choices were made. Ultimately, she spent the last 5 years of her life in a long-term care facility where she ultimately ended up passing away in a memory care unit with her family at the bedside, supported by hospice care. And so I think her story is a wonderful way to be able to think about how we can advocate for ourselves using palliative care principles. So let's first talk about palliative care. Palliative care is a relatively newer specialty, and it is care focused for patients and their families where patients are facing a serious illness at any point in the disease trajectory. This care is patient and family centered, meaning our focus is not just the patient, but the people who love that person. The care is interdisciplinary, which means that we provide this care not just with physicians and nurse practitioners, but also chaplains, social workers, other disciplines, knowing that everyone connects to people differently, and sometimes having a larger team can help us to provide better care. And as I mentioned earlier, this type of care is offered for people facing a serious illness, and it is best served when we can do this in conjunction with curative or life-prolonged care. So palliative care, I think a lot of people, when I talk to them, will say, oh, I know what that is. Isn't that hospice? And the reality is, though there are similarities, there are differences. And I'd like to now kind of highlight how things between palliative care and hospice are similar yet different. So this is the older model of palliative care. And palliative care about 20 plus years ago was synonymous with hospice care. And hospice care is that care that we get at the end of life when our life expectancy is limited to months. And so this would be the old model and really equate palliative care with hospice. But I want you now to think about palliative care being something much broader. And so palliative care, as we talked about, is something that we initiate at the time someone has a diagnosis while they're getting their life prolonging or curative care. And that palliative care, again, be initiated not just by a specialist like me, but by a primary care provider. And the goal is for that palliative care modality or palliative care treatment plan to happen in conjunction while someone is getting their curative or life-prolonging care so we can support all the needs of an individual and their family. Another way to think about palliative care is that it has many different arms of what it can provide. So certainly hospice is one portion of palliative care, but that portion is at the end of life. If we think much more upstream, palliative care can be incredibly helpful in helping families and patients understand what is going on with an individual's illness, to talk about prognosis, to offer psychosocial support, to help with symptoms, as well as establish what we call goals of care, or coming up with a plan that meets a patient's needs and is medically realistic. So when we think about palliative care, another way to look at it is thinking through the many types of care or support that can be provided. Hospice is one portion of palliative care, and that is the care that we provide at the end of life. That is for people who have a life expectancy of probably months. But what I want you all to think about now is the kind of support palliative care can provide much further upstream. One of the first things that I think is incredibly important that palliative care teams can help with is helping patients and families understand what is going on with an illness and how that illness is going to impact them. It's offering the psychosocial support that is needed when someone realizes that they have a new illness and how that is going to change their lives or perhaps their families. It is helping with discussions on prognosis, in particular when there is uncertainty on how things will pan out. It is helping people to have their symptoms managed so they can live their best quality of life, as well as having discussions on what we call goals of care, meaning having conversations about what is important, what goals and values a patient has, and how medically realistically we can accomplish that. If I think about palliative care and hospice, there are many similarities and there are a few differences, just to highlight again. Palliative care is that medical specialty that starts out providing care at the time of diagnosis when someone has something serious. Hospice is for people who are really at the end of life in the last 6 months. Both areas want to focus on patient and family-centered care, where we try to maximize someone's quality of life. And both use an interdisciplinary care team, meaning they utilize chaplains, social workers, physicians, nurse practitioners. And for palliative care, there is no life expectancy designation, so people can access this at any point in their lives. So let's move on how to access palliative care. Palliative care began in inpatient acute care hospitals, and so the great majority of palliative care that one can access is typically in a hospital. Some hospitals will provide their own palliative care services through their own clinicians, and other institutions will actually have community organizations, sometimes hospices, that will come into the hospital and provide palliative care services. There is a push to have more outpatient or community-based palliative care services because the goal is to be able to meet people more upstream and to help them earlier in their disease process. These home-based organizations can come out of hospice organizations or freestanding palliative care. Sometimes they will actually come to your house, and sometimes their freestanding clinics are connected to a larger institution. So Tennessee has a pretty good ranking, I would say, for palliative care services as we compare across the country. The Center to Advance Palliative Care, also called 𝐒𝐲𝐶, puts out a report every year, and they compare states to each other. They compare states to their local region, and they compare states to the national averages, and they're looking at hospital-based palliative care programs. So we as Tennessee are actually doing very well in our larger hospitals as we compare ourselves both to the local region as well as nationally. In general, we struggle as a palliative care, I think, specialty to provide services in hospitals with smaller beds. That being said, Tennessee, I think across all of those benchmarks, does better compared to our region and on par with the national averages. The challenge in providing palliative care services, as I mentioned, is that though we do, I think, a good job in larger hospitals, we're often seeing patients in big cities. The smaller hospitals that serve the more rural areas are challenging populations to serve because we just don't have the same services. This slide talks about that discrepancy. The white circles show where we don't have enough palliative care, and those are largely the rural areas. And this is where we need to do better. So who can provide palliative care? And how do we use trajectory to help us understand diagnoses and what to expect? So for those of you who have ever gotten to know me, you'll know that I like movies. Pandemic has made it really hard to see movies. But this one's an old one. This one is Doc Hollywood. And in the top right, you see a young doctor who you may recognize as Michael J. Fox, who is talking to his nurse. And he is a surgeon, but when he is practicing in this rural community, he ends up practicing palliative care. care. The lower left slide is Doc Hoag, who has been practicing all sorts of medicine from OBGYN to internal medicine to palliative care. And the reason why I put this slide up is that when we think about palliative care services can be provided by someone like the doctors I showed you in that movie, and that would be considered primary palliative care. And those are clinicians who are not trained or specialty trained in palliative care, but are comfortable managing the things that really all physicians and clinicians should. How to have conversations about difficult diagnoses, how to talk about end-of-life care, how to initiate hospice services, how to manage basic symptoms. Specialty palliative care is the kind of care someone like me would provide, or one of my colleagues who have had specialty training in this field, where patients or families are dealing with the symptoms maybe more difficult to manage, and there may or may not be complex dynamics in patients and families. The goal is ultimately, as we move through medicine, that every clinician, healthcare provider has the ability to provide some basic palliative care service. So I would challenge all of you to learn more about this. I've had quite a few referrals from medical students, from nurses, sometimes even families. I think this is a piece that all of us can do to move this forward. So how do we get the best care? Meaning the best care that makes sense for us when we're facing a serious illness. In the hospital, we refer to that as gold concordant care. When I think about how we do that, I think a lot of it is dependent on us understanding kind of what to expect. And that's true not just in medicine, but I suspect in life in general. As a young resident a long time ago, we didn't spend a lot of time on trajectory. And thankfully now we spend a lot more emphasis on trajectory. And what that means is, what is the path of life for a person with a given illness or injury? And what we know as healthcare providers are, depending on the diagnosis or a health condition you have, what life looks like for you will vary depending on that diagnosis or condition. And there are graphs that illustrate that. When we as healthcare providers can share this with the people that we are taking care of, and when patients and families understand this better, they have a better sense of what to expect. For example, if someone is suffering from something like Alzheimer's disease or dementia, typically they are slowly deteriorating over time until at the very, very end there's a precipitous drop. And if we can share with people what that looks like, they'll know where they are on that continuum. Versus something like a stroke, generally, people are living their life as they would and have a rapid sudden decline. And then a proportion of people will improve with some disability, but make quite a bit of improvement, while others will still stay pretty debilitated. Cancer has its own trajectory. Organ failure has its own trajectory. I don't want to go into every last trajectory, but I think it's important, if you are a patient or family member, to talk to your healthcare provider to get a sense of what that looks like for you or your loved one. And it's for healthcare providers for us to be very intentional in explaining to people what to expect. If we can give this information to the people we are caring for, we can better partner and make better decisions. So partnering leads me to engaging patients and families and having discussions on goals of care. Why is that important? This slide has a couple movies as well, but it depicts 4 different people who had 4 different wishes on what they wanted at the end of life. The top left shows Jenny from Forrest Gump, and she passed away in her home in her pajamas in a pretty peaceful way. We have the bottom left with Jack Nicholson and Morgan Freeman in the bucket list, and they went on a wild adventure before they both passed away. Brittany Maynard in the top right made decisions on what she wanted and moved to a different state to be able to live and end her life the way she wanted. And finally, we have a gentleman at the back who's in the ICU on all different types of life support. The reality is that every human being is different, and what their goals and wishes are going to be very different, and what one person wants may be different than someone else. And so the reason why it's important to engage people, whether you are a patient or a family member or a healthcare provider, is this is not a time to make assumptions. We really want to get this right. And the way we do this is by having a conversation. When we have these conversations, it's important to remember to revisit these conversations. I shared with you my patient, Mrs. W. When she was married to her husband and they were both doing well, she was very okay with coming back to the hospital, even going to the ICU if she got sicker. As her functionality decreased and she was able to do less and remember less, she was less interested in coming to the hospital and ultimately decided she didn't want to come back and use hospice care. So it's important to go back and revisit these conversations, because what we want now may change in the future. One of the things when we have conversations is we want to be very clear about what we mean when we use words. The word that comes up in the hospital all the time is better, and better can mean different things to different people. And I say this to remind ourselves that we are precise in our communication. If an individual is in the ICU and the ICU doctor says, gosh, he's getting a lot better, does that mean that he is so better he is going to go home? Does that mean that a lab test got better? Does that mean that he's better from just an hour ago? So it's important to drill down on the words that we use and clarify so we're all on the same page. And so ultimately, we're moving in a direction that makes sense without ambiguity. When we think about dying in America, there are statistics that I can show you that I think point out that we have opportunities to do better. We know that 70% of deaths occur in older adults. And when I say older adults, I'm talking about the population of individuals over 65. 7 out of 10 Americans want to die at home, and yet only 25% of Americans actually do. When we think about chronic diseases like heart disease, lung disease, kidney disease, 7 out of 10 Americans will die from a chronic disease, and over 90 million Americans will have at least one chronic disease. Now, 80% of us with chronic diseases want to avoid hospitalization or ICU care at the end of life, but the problem is nearly half of us die in a hospital. So what's getting in the way for us to be able to achieve these goals? And certainly this is a complicated problem, and I don't have all the answers, but here are some things to try to help us put ourselves in the best foot forward to achieving what I would talk about as goal concordant care, getting the care that you want that makes sense for you, that is medically realistic. So there are barriers in achieving the best possible care. And when I talk about these barriers, I want to make it very clear. I'm not blaming anybody. I'm just highlighting some of the challenges that exist when people are trying to seek out this care. And the first barrier I want to talk about is healthcare providers. Healthcare providers, I think, are wonderful people, but we, like human beings, can't and don't always get it right. This study, which discusses prognostication that was published 20 years ago, still is true, and there are multiple studies that have shown the same thing, that physicians, unfortunately, are not really good at determining prognosis. And this study looked at patients who were terminally ill with physicians who determined or guesstimated based on their judgment what they thought survival was. And what the study showed was 20% of the time, physician predictions were accurate, which means that 80% of the time they were wrong. Now, if my kids took a test and they got 20% right, they wouldn't still be in college. And so we have a lot of work to do here. When we made our predictions that, again, were not in general accurate, they were generally optimistic. So the problem is we are letting patients know that they probably have more time when they do. And when we look at what this prognostic factor is typically we as physicians overestimate prognosis by a factor of 5. The more often you see someone, the more frequently you see them, and the time between contacts goes down, our ability to prognosticate goes down. And I think what that means is we as physicians often get attached to our patients, and we too have a hard time having these conversations because we may not be seeing things as objectively. And again, the problem here is if we can't convey to our patients and families what an accurate prognosis is, how will someone make timely decisions if they themselves don't have the facts? The next study I wanted to highlight is basically generally the discomfort that we have as healthcare providers with the truth. And the question is, if we had the crystal ball that gave us the exact amount of time that someone had to live or what the prognosis was, would we tell someone? And in this study of 326 patients and almost 260 physicians, we found that just a little bit north of a third of the time, physicians would provide a frank estimate. And again, this is when they had the answer, which means almost 2/3 of the time they would not. And again, I don't think it's because people are trying to be difficult. I think these are difficult conversations that people don't know how to have if you've not had training for this. Also, people don't know what the reactions are going to be. And so this is a place that we as healthcare providers can do better. Within palliative care, this is one of the things that we train our trainees about is giving information in a kind and compassionate way where people can make decisions together. The next category in terms of barriers I want to talk about is the healthcare system. Sticking to that movie theme, this is a slide of The Maze Runner, which I truthfully didn't like the movie, but the slide really, to me, impacts, I think, how scary the healthcare system can be. We find ways to get into the healthcare system, and once we're in the healthcare system, it's really hard to navigate. I have taken care of several physician patients who have worked in this hospital, and they have had enormous difficulty navigating how to take care of themselves as they progress through an illness and near the end of life, even though so they have more connections than I do. Mrs. W, the woman that I talked to you about earlier with that slide, she was very clear about what she wanted, and she knew how complicated healthcare was, and so did her family because they'd had some previous experiences. And so they were incredibly intentional, as some of my patient physicians were. And I think that is the trick in being able to navigate the healthcare system. And so if we don't point out to families and patients how difficult this is, or if patients and families don't recognize this themselves, it can be very bewildering. The next area I want to talk about is families, and families are lovely. I promise not saying anything negative, but the complexity that families have is enormous because they are trying to advocate for the person that they love, hope that that loved one does not suffer more, and also hope that they can live longer. And that's a really confusing place to be in the setting of uncertainty and not knowing, even if you have a healthcare background. And that can make things hard. We as human beings, I think, make decisions not by ourselves, but in a bigger unit. And patients will often do things for families. And so trying to support families and making sure we're all on the same page and offering them support can be huge. And then finally, patients. Patients can be a barrier, and not that I'm blaming them again, but for patients, it's really hard to be a patient. It is scary to have a diagnosis. It is scary to think about what kind of symptoms you might have and if they can and cannot be treated. People are afraid about death and they wonder what the end of their life will look like. They're afraid that they see things in reports. We see right now with the news and COVID, in particular back in the spring, of how lonely and frightening people with COVID were at the end of their life. And this is frightening. And as a country, as a community, we generally shy away from conversations about death. And so people think about these things on their own, trying to overcome some of these barriers are really being able to engage people in conversations and really address the elephant in the room, because all of these are very surmountable. So what can we do as healthcare providers? I think the first and most important thing is to have the conversation. With my patient, Mrs. W, we had lots of conversations over time, and we didn't have them every visit, but it depended on how things were going, how her health was, and what was on her mind. We talked a lot about what to expect with her trajectory. She suffered from dementia at the end, and so at every visit, I would let her family know, right now she's forgetting X, the next thing that's probably going to come is Y. And so they knew what to expect. And when that happened, they were able to come back to me and say, okay, this happened. What should we be looking at now? We've already gotten that caregiver to make sure she doesn't fall. We talked about prognosis, so they knew as she reached certain places on that trajectory, what indicated the end of life. And so when she was having trouble swallowing, when she was having trouble getting out of bed, we knew time to engage in hospice care. The other piece I think healthcare professionals can do and patients and families can do is ask the simple question to yourself or the people around you is, gosh, what is really the most important thing in your life? What is your priority? And make sure that's clear to all of us, to everybody in the family and to everybody in the institution who is taking care of you. Because if we can focus on what that goal, what that priority is, then we can build a plan that is consistent with that and hopefully achieve the goals that one is seeking out. And finally, it is important to talk about your wishes, to complete advanced care directives, to have more conversations, and we'll talk more about that a little bit later. When I think about the coronavirus pandemic, the world is upside down, healthcare is upside down, and it's been incredibly hard because some individuals are afraid to go to the hospital. Some individuals are afraid of what they might be told. People are afraid to be around each other, and people are afraid to talk about this. If there was ever a time to be intentional in your healthcare, this is the time. Even though we are socially isolated, thank goodness for phones and video chat and whatnot, it's important to talk to people about your priorities. If you're living in an independent or assisted living facility, it's a good time to talk to your family. If you are the family member of someone in a long-term care facility, it's really important to engage the team taking care of your loved one on what is going on. We see a lot of families who haven't seen their loved ones in months, and it's hard to make decisions when you don't know what's going on. But this is that time to lean in and to find out what's going on and to really engage. My experience is that when we are intentional, whether you are the patient, the family, or the healthcare provider, it is the best way to be able to promote goal concordant care, or is that very best care for you. So take-home messages. Palliative care is appropriate for anyone facing a serious illness at any point in their illness. We should think about disease trajectory, which is that path of what may come forward when someone's diagnosed with an illness or injury, and think about that when we're making our decisions. It is important, whether you're the patient, family, or healthcare provider, to talk about what is important, talk about your goals and values, and then go back and revisit these conversations in the future, depending on how life is going more frequently or less.
Thank you, Dr. Karlekar, and thank you to our listeners for joining us today. If you have any questions regarding palliative care or anything that was mentioned in today's podcast, please visit our website at www.emergencyltc.org.